Hello everyone, I'm Tatiana and today we're going to be discussing different aspects of pulmonary fibrosis. I hope you enjoy this presentation. So what is pulmonary fibrosis? Pulmonary meaning lungs and fibrosis meaning scarring. Pulmonary fibrosis is a lung disease that the tissues become damaged or scarred over time. This thick, stiff tissue makes it harder to breathe properly. There is irregular and abnormal air spaces in the lungs, and pulmonary fibrosis is not just one disease, it's actually a family of diseases that have very similar characteristics. Scarring can be from many different things. No one is certain how many people are affected by pulmonary fibrosis since it's so broad. One recent study did show estimation that idiopathic pulmonary fibrosis, which is just one of more than 200 types, affects 1 out of 200 adults over the age of 60 in the United States. So if we do that math, that's about 200,000 people living with pulmonary fibrosis today. Approximately 50,000 new cases are diagnosed each year, and as many as 40,000 Americans die from idiopathic pulmonary fibrosis each year. It is difficult to know the incidence of pulmonary fibrosis because over half are initially misdiagnosed. It can be challenging for doctors to figure out what causes pulmonary fibrosis. Sometimes they're able to identify one or more causes of the disease. This includes drug-induced, radiation-induced, environmental, autoimmune, and occupational. In the United States, environmental and autoimmune causes seem to be the most common types of pulmonary fibrosis of a known cause. Pulmonary fibrosis with an unknown cause is called idiopathic pulmonary fibrosis. Non-modifiable risks include age, which even though it can be diagnosed in children, it is more rare and is much more common in middle-aged and older adults. Sex, pulmonary fibrosis is more common in men. Genetic factors have recently also shown an increased risk, and a recent study by the Respiratory Medicine Journal showed that 20% of the patients had a parent and or sibling previously diagnosed with pulmonary fibrosis. And they found that the presence of a family history of pulmonary fibrosis showed a strongest association to the disease. Modifiable risk factors include smoking, especially cigarette smoking, environmental factors, which are very high risk. This includes metal, wood, dust, exposures to agriculture, farming, livestock, chemicals, and smokes. Really, any kind of pollutants that are known to damage the lungs. How the tissue exposure to environmental toxins predispose in pathogenesis of this is still being researched and is largely unknown. However, it is known that chronic damage to alveolar and bronchial epithelial cells play a role in genetically susceptible individuals. Recent studies have also shown that there is a link between pulmonary fibrosis and gastroesophageal reflux, and also type 2 diabetes, especially in idiopathic pulmonary fibrosis. Cancer treatment and having radiation to the chest and using certain chemotherapy drugs can also increase this risk. Idiopathic pulmonary fibrosis is the most common and most fatal condition with a median survival of 3 to 5 years following the diagnosis. Fibrosis in idiopathic pulmonary fibrosis is generally progressive. Current pharmacological intervention and inexorability leads to respiratory failure due to the obliteration of the alveolar units. Idiopathic pulmonary fibrosis affects approximately 500,000 people in the US and Europe. Clinically, patients generally present with increasing dyspnea, which may be associated with a dry cough and nonspecific systemic upset. Cigarette smoking has been associated with an increased risk along with certain viral infections. Complications and comorbidities. Pulmonary hypertension, or high blood pressure in the lungs, affects only the arteries in the lungs, making it a little different than the systemic hypertension. This happens because the smallest arteries and capillaries are compressed by scar tissue, causing increased resistance to blood flow in the lungs. This raises pressure within the pulmonary arteries. Right-sided heart failure, or Pulmonary, is a serious condition and occurs when the ventricle has to pump harder than usual to move blood through particularly blocked pulmonary arteries. As pulmonary fibrosis progresses, it can also lead to blood clots in the lung and a collapsed lung or lung infections. Respiratory failure also happens when blood oxygen levels fall dangerously low and is usually end stage of this chronic lung disease. Long-standing pulmonary fibrosis also increases the risk of developing lung cancer. And recent studies have shown that gastroesophageal reflux and obstructive sleep apnea are also common comorbidities. Once diagnosed, the next step is to try to diagnose the specific kind of pulmonary fibrosis, since there are over 200 different kinds. A special kind of X-ray of the chest, called a high-resolution computed tomography scan, allows a better view of the lung tissue that normal imaging does not do a very good job of showing. The HRCT scans gives a close-up view of the lungs, providing more detail, and this is critically important to determine the type of pulmonary fibrosis. When indicated, a lung biopsy can also help to decide which treatments might be helpful to the patients. When looking at lab findings, one of the most significant findings is low blood oxygen levels. This is because of the scar tissue blocking movement of oxygen from inside of the air sacs into the bloodstream. The brain senses this and triggers a feeling of breathlessness or shortness of breath, and this can be a future problem during exercise. The two medications listed in the second to last bullet are approved by the FDA to slow progression of idiopathic pulmonary fibrosis. In extreme cases, doctors may recommend a lung transplant, but overall, treatment depends a lot on the type of pulmonary fibrosis the patient has. Pulmonary function tests consistently show decreased levels in forced vital capacity, which is the maximum volume that can be exhaled as forcefully and quickly as possible, and forced expiratory volume in 1 second. The ratio of FEV1 over FVC is usually within normal limits. Their vital capacity and total lung capacity can also show decreased signs. This is due to the fact that pulmonary fibrosis is considered a restrictive lung disease. Some of these values can be debated because it depends on the progression of the patient's pulmonary fibrosis, but overall it is agreed that they will present with decreased volume on inhalation and a proportional decrease in total volume. Presentation includes stiffening of the patient's lungs. This is because of the scar tissue and an inflammation, making it difficult for the lungs to stretch. So when breathing, the patient has to work extra hard to pull air in. This is why patients' work of breathing can be observed by relying on more of their accessory muscles to help. Usually this includes overuse of the traps, the scalenes, and the sternocleidomastoid muscles. The brain responds to this extra work by triggering a shortness of breath feeling in the patient, and this can be progressive. Other common presentations include dry, non-productive cough, decreased SpO2. This would be abnormal if it was below 95. We can also notice some clubbing in the patient's fingers. Both of these are causes of decreased oxygen. Blood pressure can be normal or elevated, and signs of pulmonary hypertension. And when auscultating the lungs, it is common to hear fine crackles in the lungs because of the affected air sacs. Most patients tend to have this. The declines in pulmonary function and exercise tolerance are common with patients with pulmonary fibrosis. Patients with idiopathic pulmonary fibrosis have a limited response to conventional pharmacological treatments. Pulmonary rehab as a non-pharmacological approach can be promising. This can improve the ability to cope with daily living and reduce dyspnea and improve exercise tolerance in the patients. This also depends on the severity. Patients who have recently been diagnosed with pulmonary fibrosis will have a better exercise tolerance than those that their pulmonary fibrosis has progressed. Low blood oxygen levels, as discussed earlier, can trigger breathlessness feeling or shortness of breath in patients. This can be problematic during exercise. If this is a huge problem, supplemental oxygen can be prescribed during activity, but as the patient's disease progresses, they may need to be on it more often. It is important for us to monitor patients' SpO2 levels at rest and during exercise because of this. Because of these symptoms, the patient may need intermittent rest breaks, and it is also important for us to monitor their blood pressure and heart rate to make sure they are not being overworked. This slide shows an example of some of the different short and long-term goals that are appropriate for a patient with pulmonary fibrosis. These include, but are not limited to, improved activities of daily living, walking household distances, decreased shortness of breath, walking community distances, and increased overall activity tolerance. The variety of these goals really depends on the severity of the patient's pulmonary fibrosis and how it affects their day-to-day life. Similar to any other patients, we want to make sure that these goals are individualized. Pulmonary rehab has been shown to have positive effects on exercise tolerance, activities of daily life, and quality of life. Evidence shows that treating patients with pulmonary fibrosis is very limited in its effectiveness in stopping the progression of the disease. For this reason, maintenance is very important for us as physical therapists. Pacing, diaphragmatic breathing, and just getting the patient moving can help them increase their exercise tolerance, especially because a decrease in exercise tolerance has been shown to have a high relationship with mortality. These are things that can be included in the plan of care but are not limited to psychosocial evaluation, which takes into account the impact on the physical, psychological, and social well-being of the patients, since this disease is a very fatal condition with no known cure. Recent studies have shown that most patients with pulmonary fibrosis have symptoms consistent with depression or low mood. This is likely attributed to the psychological trauma associated with the disease. The psychological trauma caused by the disease also appears to derive from altered perception of self. This is why it's very important to evaluate the psychosocial health of those with pulmonary fibrosis, because it can impact their further treatment. Another thing that can be included in the plan of care is patient education. This can be helpful in many ways to improve the patient's overall quality of life. An example of this can include educating the patient onto how to properly pace themselves during activities. Helping improve the patient's posture can also be beneficial to help their overall work of breathing. Any type of aerobic exercise is beneficial to help improve the patient's exercise tolerance and also their endurance, shortness of breath, and fatigue. We can also help the patients by teaching them different kinds of breathing techniques that they can use to help them breathe more effectively. This can include diaphragmatic breathing, stacked breathing, and spirometry. The general principles of exercise training are no different than those of healthy individuals. The frequency, intensity, and duration are specific to the type of activity and should be tailored to the patient's ability to safely perform these. Evidence shows that the optimal intensity cannot be defined by the information today, but it has been shown that moderate intensity in general can be beneficial. Overall, treating patients with pulmonary fibrosis is really a team effort of many different professions. Of course, this includes us as physical therapists, but alongside with doctors, nurses, respiratory therapists, social workers, dietitians, and many more. When starting an exercise training program, an exercise assessment is needed to individualize the exercise prescription, evaluate the potential and the need for possible supplemental oxygen, the identity of cardiovascular comorbidities that may be present, and to make sure that the patient is safe during the intervention. So, reasons that we may need to modify or discontinue treatment would include abnormal vital signs, symptoms that may be uncontrollable, which would include anything that is progressive, signs of acute hypoxia, and also difficulty breathing. Because of these reasons, it is very important that we continuously monitor our patients throughout treatment. We should be observing them for their work of breathing, their general appearance, and see if there's any kinds of signs of distress or cyanosis or abnormalities while they are exercising. It is crucial that we continuously check their SpO2 levels, their pulse, and even their blood pressure at rest and while implementing exercise. Here are some of the different references that were used. I hope this presentation helped you learn a little bit more about pulmonary fibrosis and how to treat these patients in the future. Thanks so much for watching.